Today as well, I will explain to you in depth because in different 2 to 3 groups, I was um, just in questions that what is CCRISP, and most of the people are confused related to CCRISP and abdominal examination. So I'll try to make as much simple as you can, because currently I'm working in this system in the NHSC. So I'll try to make it as simple as I can um, for you guys. Just give me 1 second so that I open slides for you. Okay, guys. So I know this secret is little bit tricky, and specifically when you have a station of the abdominal examination or chest examination, the command is related to this one. Then you are really, it becomes very tricky, and specifically when the patient when you are having lot of stress related to exam, then it becomes difficult to judge it immediately if you don't have prior clarification in your mind. Second, why is this happening? So there are 2 scenarios which are related to CCRISP, and those must be examined according to the CCRISP protocol. And then there are other stations which are not CCRISP but look like CCRISP, right? So first of all, what is CCRISP? That is important. CCRISP means care for critically ill surgical patients. Care for critically ill surgical patients. That means it is CCRISP. So ideally, first of all, what is the difference between CCRISP and ATLS? This is important to clear to you as well, because in ASCC stations, sometimes I have seen to ATLS page where you have to apply the ATLS protocol. Some candidates say CCRISP and vice versa. So CCRISP is for those critically ill surgical patients who don't have trauma. So the patient is ill, the problem is surgical, but the patient is not having any trauma. Those patients are managed according to CCRISP protocol. One thing. Second, those patients who have either the burn, either the head injury, the pelvic injury, abdominal injury. So those patients coming to you after burn, after all these things, those patients are managed according to ATLS protocol. So first thing, make it clear, right? Second thing is that, do you need to go through all the ATLS 10th edition and all the 400 pages book of the CCRISP? So because this is not exam for the CCRISP, this is just to mention steps. So you don't need to go through all those heavy books, right? So yes, you can read out some points if you are not clear, but don't go into depth of those. Those are a separate syllabus for 10 to 15 days. So don't go into depth of those books. Otherwise, you will confuse yourself. So rather than follow the guidelines and then you answer according to the scenario. So let's see what are the scenarios which are coming in the exam where you have to examine the patient according to this protocol. There are two scenarios. For whenever I ask my candidates to prepare for the exam, I always say one important thing, and that is obviously coming from our teachers, great teachers. So first thing to ponder upon is 1 minute of scenario. That is the key. Listen, guys, you have exam probably in 10 days, maybe 7 days. So if you are not um, putting your head into the question written on the board in 1 minute, you are probably going to fail your next 9 minutes on the whole station and probably the whole exam. So this 1 minute is the key. I give you a few examples, and these are the true examples of the candidates. One of the candidate who appeared in UK, there was a station of chest pain, and the command was to take the history. But the candidate in the rush went inside, started examining the patient, and literally after 2 to 3 minutes, the examiner interrupted and asked, please, this is the history station, not the examination station. So please, first of all, this is extremely important. Read the scenario carefully, read the command, and then act according to the command. Second, there was a patient, there was a station for the abdominal examination, and the station was for CCRISP, and someone went inside and did the normal abdominal examination, and result was as expected. Okay, so this is important. First thing, first minute is the key. So first of all, prepare yourself very well, and then first minute. Okay, so here I have two scenarios for you. First of all, how to recognize that this station is the CCRISP and this station is not abdominal, simple abdominal examination. So there are two stations for the CCRISP. There are two stations for the CCRISP. One is the command for abdominal examination, other is for the chest examination or the respiratory system examination. So I will go one by one. So first, let's see what that is why I was not starting actually. Just 1 minute, guys. Let me solve this problem first. So hopefully it will be resolved now. Okay, so there is a first scenario. In this scenario, we would say that the patient is post-operative, day 6, and now the patient has presented to you post-operative day 6. The patient is most probably having right hemicolectomy, and this right hemicolectomy After 6 days, now the patient is having suddenly maybe increased body temperature, number one. Number two, abdominal pain. Number three, the patient is having tachycardia. Number four, the patient is having high respiratory rate. So now there is a nurse in or maybe your SHO in the ward, and they have called you um, to see this patient. Okay, so this is this is from the start that the patient is post-operative, day 6, maybe right hemicolectomy, maybe left hemicolectomy, maybe some other operation, and now the patient is having increased temperature, there is pain, tachycardia, increased respiratory rate, and patient is having low blood pressure as well. Okay, so this is all first scenario. Second scenario is that there is a patient post-operative, maybe day 8, maybe day 10, maybe day 6, so whatever. The surgery done was something on the hip. So it may be total hip replacement. It may be some injury after pelvic injury, okay, pelvic fracture. So any injury related to the pelvis. And now the patient is having high respiratory rate, low blood pressure, tachycardia, and chest pain. So there is high respiratory rate, number one. Number two is blood pressure is low, patient is tachycardic, and patient is having chest pain. Okay, so this is the scenario: blood pressure, chest pain, and then tachycardia. Okay, this is the second scenario. And there is a third scenario which I give to you, and then you have to answer me which one is the patient you have to manage according to the CCRISP protocol, and which the patient you have to proceed with the normal examination. So what is the third scenario? The patient has presented to you in emergency A&E, and the patient is having pain in the abdomen, or the right iliac fossa, or the left iliac fossa, or the right hypochondrium. So I give you example of all the three: right iliac fossa, left iliac fossa, and the right upper quadrant, right? So this is the third patient, and now this patient is having has come to you, and now you have to examine this patient, right? So now examine this patient and then present to the examiner. So now you people tell me in the chat that which patient is for, tell me in the chat that which patient to be examined by the CCRISP protocol, and which patient to be managed by the simple abdominal examination.
Sir, all the post-op cases are managed by CCRISP protocol, and the patient come in the emergency room with the complaint of left or right iliac fossa is managed with abdominal examination sample.
Very good. So very good that just a second. That you are right, that those patient post-operative, these meant to be examined through the CCRISP protocol and managed accordingly, while the patient with who is pre-operative, that must be managed according to the only the abdominal examination, right? So whenever you will read the book, the CCRISP book doesn't say like that. It says that any patient who is critically sick, either the post-operative or the pre-operative, must be and have surgical problem, must be managed according to the CCRISP protocol. And that is the rule, and that should be, it makes a sense as well. Why? For example, there is a patient lands to you in emergency with pain in the right or the left lower quadrant. Okay, and now the patient is having perforated appendix. The patient is going towards the peritonitis. So you have to manage this patient according to the CCRISP protocol, manage the patient, all these things, right? But listen again carefully. Related to exam scenarios, only you have to perform CCRISP for the post-operative cases, not for the pre-operative, right? So this is for the exam. Otherwise, you see that whenever we are dealing with the diverticulitis, dealing with the diverticular abscess, whenever we are dealing with the diverticular perforation, we are dealing with the cholangitis in the ASCC cases. All these cases are managed. We say that I will manage this patient according to CCRISP protocol. Similarly, if the patient is having acute pancreatitis, we say that the patient will be managed according to CCRISP protocol. But reason again, however, in the exam scenarios, only the post-operative cases will be managed with the CCRISP protocol. The pre-operative cases will not be managed according to CCRISP protocol. Dr. Amir, I will take all the questions at the end. Please take your notes, and then I will take your questions for sure. Okay, now let's go towards that, how to perform the examination and how the scenario will come. So this is also another big problem. So for example, the first scenario, we take the first scenario that the patient is having this problem, and now the patient is coming to you with the abdominal pain. You have been called in the ward. So how will you perform the examination? So this is the first scenario, right? So what you will do, you will go inside. First of all, you will introduce yourself to the examiner. Okay, so sorry, I was, if I'm not missing anything. So this is the point in the scenario outside that will indicate you that this is the CCRISP. When you will go inside, in the CCRISP station, if this is the CCRISP station, then you will see inside that there are a lot of files, charts. Number two, the patient is lying on the bed, maybe with the oxygen mask on the face, may not be with the oxygen mask on the face. And the examiner will be carrying few of the charts along with him, ECG charts and all these things. And these are available most of the time with the CCRISP patients, right? This is the second indicator that the patient, this station is for CCRISP protocol. Then you see this patient with post-operative abdominal pain, post-operative day 6. So we are dealing with scenario number 1 now. So you will go inside, introduce yourself with the examiner and say that, okay, I want to proceed with the examination. And you will go and speak to the patient. They say that, so what you have to speak now, the patient. The thing is that outside, most of the time, you will be having the patient's name, patient details, right? So if you have the patient details already, you need not to go inside and say, hello, I am Dr. ZQ. May I confirm your name and age, please? There's no need to do that, right? If the patient, you have already the details. This is very important. If you are already having the patient details written on the scenario, don't go inside in the routine way. You will go inside, hello, Mr. McDonald. I am Dr. ZQ, part of the surgical team taking care for you. May I just confirm your date of birth? So that is for the identity purposes, right? May I confirm your date of birth, just please, for identity purposes. So you will say this thing rather than saying, may I confirm your name and age, please, and then going with the same things. And then you will say that once the patient say that, yes, my name is this one and my age is this, or my date of birth is this one, or my age this one, then you will say, okay, Mr. McDonald, for example, I from your file or from your chart, I came to know you that you have some operation about 6 days ago on your colon, and now the nurses or my junior fellow doctor, whatever written on the scenario, told me that you have some problem with the with your tummy, you have some pain in the tummy. Is it okay if I go for the examination, right? So after that, you will go with first step after this introduction. So you are here, this will be your difference in your introduction. Your introduction is totally different here, right? Second thing, now you will go with your start with your GPE. So you'll say that first of all, I want to see your hands, or like you are doing your GPE as a routine. So you see, and then you will say, okay, Mr. McDonald, obviously you will ask the patient about the pain first and offer the analgesia as well. And then you will say, okay, I want to proceed with the examine your tummy. The patient is lying. You will never ask the patient to sit up or to adjust the position. If you want to, you can mention to the examiner that I want to adjust the position, but you will not sit up the patient, right? So now, when you are taking off the gown, this is the important thing. When you are taking off the gown, you will see that there is a dressing on the abdomen. So this is the key difference in the abdominal examination. Either the patient is for CCRISP or patient is for generalized abdominal examination. So if the patient is having...
Sorry to interrupt you. I want to ask something here. Sir, do we expose the patient right now after the introduction, or when we palpate the abdomen?
Will not you inspect the abdomen?
No, I'm asking about exposure of the abdomen.
So obviously you have to expose the abdomen before inspection.
Okay.
No, that is why I was asked that. Ask the question at the end, please. I don't mind asking the question, but it at the end, if you ask the question at the end, it will clear everything. Okay. So expose the abdomen, and then now you have to go with your usual inspection. First, obviously, you have 4 steps. You have to complete those steps. So first you go with the inspection. You ask the patient, obviously you ask the patient first. Every time you are with the patient, you ask about analgesia. In this patient, specifically ask about analgesia. So you say, are you comfortable with this? Are you okay? So you expose the patient, you inspect the breathing pattern. Here the breathing pattern will be obviously shallow breathing, rapid breathing. Abdomen will not be, the patient will not be taking deep breaths. So you have to observe this thing. So take your time, do the inspection, and then you will say gently, if you don't mind, can I examine your abdomen? Okay, examine your tummy. And here you have to reassure the patient. This is important. Reassure the patient. I know you have pain in the tummy. I will be very gentle to you. And as soon as you have pain, let me know. I will stop my examination. So this is important. This statement, write down. I know you have pain in your tummy. I will be extremely gentle. If you have any pain at any point, let me know. I will stop my examination, right? So now, you first thing, obviously, you have to remove the dressing. So remove the dressing, and now after removing the dressing, or sometimes the examiner says, okay, consider it is removed, because they don't want the dressing to be taken off every case. So there are 20 patients in the morning and the 20 in the evening. They don't want 20, 40 times dressing to be taken off and then put on. So you have to ask and the examiner will say, okay, consider it is, there is a midline laparotomy. Okay, the examiner will say that, and then you will start examining. So if the patient, for example, this patient is with midline laparotomy, so you will start examining the patient in a standard way, that is starting from the left iliac fossa, moving towards the right iliac fossa, right upper quadrant in an S shape. So you will move like that. So you start as soon as you put your hand, but remember, it is superficial palpation. First you will do superficial palpation. So as soon as you start performing superficial palpation, the patient will jump up and say that, sorry doctor, I am in extremely pain. So when the patient is saying this thing, it means, it confirms that now you have to abandon the examination, generalized abdominal examination, and you have to move towards the CCRISP. So you will start the CCRISP examination now. So what is CCRISP now? Until here, it is the same as the abdominal examination, because in the commands it is written. They will never write that do the CCRISP. They will say do the abdominal examination. So you will start. You will say to the examiner that I feel that this patient is critically sick, and I need to perform CCRISP examination. So what are the things so far you have noticed? You have noticed that the patient is having severe abdominal pain and tenderness. Number two things. Number three is increased respiratory rate, right? And sometime, and it might happen that when you are taking the pulse of the patient, the examiner will say, okay, the pulse is 100, 110, 120, and you feel that it is tachycardia. But when the patient examiner is saying like that, don't switch at that time to the CCRISP. You have to switch to the CCRISP when you see that the abdomen is severely tender and it is even on the superficial palpation. No steps of the CCRISP. You know what are the steps of CCRISP? So you will go from airway. So I have told already what are the steps of CCRISP, and I'm sure that all of the candidates, my candidates, they know how to describe that particular sentence. That is, I would write to attach high flow oxygen. There are 5 things to be attached immediately. I would write to attach high flow oxygen, pulse oximeter, 2 wide bore IV lines, cardiac monitor, and insert the Foley's catheter. So you have to say these 5 things, okay? And then you will come towards airway, okay? So at high flow oxygen is attached to, you will ask the patient to open the mouth, see if it is clear, everything is fine, that's fine. Now you are going towards the, after airway, towards the breathing. For breathing, you will perform all the steps. So what are those steps? You know, first the inspection you have already done. Now palpate it. If there is any surgical emphysema or anything else, palpate it gently, and then after that do gentle percussion and do the auscultation. But remember, this patient with midline laparotomy, you need not to sit up the patient, right? So do the auscultation only in the from the anterior chest. Don't go to the posterior chest at this stage, right? So do the anterior auscultation, and then after anterior auscultation, meanwhile you ask the examiner what is the oxygen saturation. So he will tell you, okay, oxygen saturation is 70%, 80%, 90%, whatever. You can say that, okay, increase the high flow oxygen, increase the rate, or maybe start to the airvo, or like these things. So you will say that. Then you go to the rest circulatory part. When you go to the circulatory part, ask immediately what is heart rate, what is blood pressure. Okay, so when you say ask the examiner what is heart rate, so the examiner will say that, okay, heart rate is 110. What is the blood pressure? 70, 60. So your answer should be, can you please attach, you have already passed 2 wide-bore IV lines, can you please attach Normus line, okay, slide solution, okay? And you have to tell here the rate as well, that you want a bolus. Usually we give 500 mils in 20 minutes, 15 to 20 minutes. So you have to say this thing, that and then I will. And the heart rate, blood pressure, peripheral circulation, so these things. And then after C, there is D. In the D portion, you know that the most important things are to see the patient's GCS. So you will ask the patient name. You will also ask the patient to show me your hand, or just lift your limb. So you can ask 1 or 2 commands, open your eyes, and all these things. Okay. And in the D portion, do check the pupils of the patient. This is important as well. Do check the pupils of the patient. Now coming towards the E part, you have to say that I want to see the temperature of the patient, expose and see the patient's abdominal wound, and the legs for DVT. Legs for DVT, and also for the stockings. Meanwhile, you are taking the bloods. This is important thing. You are taking the bloods, and when you are saying that pass 2 wide-bore IV lines, pass 2 wide-bore IV lines. So you are asking the examiner to pass 2 wide-bore IV lines. It means you are taking the bloods for, number 1, for the blood sampling. It includes FBC, urea and electrolyte, and liver function test, so CRP, these things. Number 2, you are taking the blood for cross match. Number 3, you are taking the blood for blood culture. Number 4, you are taking the blood for VBGs and to check the serum lactate levels. And then ask that I need ABGs level as well. One more thing is ECG. So you have to mention about the ECG of the patient, and chest X-ray, bedside chest X-ray, and bedside ultrasound examination. So I can mention on this screen for you what steps you are going to do. So first step will be general physical examination, GPE. Sorry. Okay. So here, first thing can be GPE. After the GPE is performed, you will go with the inspection of the abdomen after exposure, obviously. Then after that, you will perform superficial palpation. And If the patient is feeling severe tenderness, you will switch to the CCRISP. In the CCRISP, you will do A for AMA, and you will attach obviously high flow oxygen. Ask the examiner about SpO2 and see the airway completely. Ask the patient to open the mouth and see if there is any obstruction. See the nostrils as well. Then B for breathing. So inspection you have already done. Make sure you have noticed the respiratory rate and there is no injury on the chest and the chest wall movement. Then you will perform the palpation. Palpation, you will see that if there is any tenderness and equal chest movement, and then also if there is expansion is fine on the both sides, and also if there. So this will be in palpation. Then percussion, gently percuss, and then auscultation only on the anterior chest. There is no auscultation on the posterior chest for this station. At the end of the station, you can say to the examiner that patient is in severe pain. That is why I did not perform the auscultation from the posterior aspect. Okay. Then there is circulation. In the circulation, first thing to see is obviously pulse. Then blood pressure. Ask about the blood pressure. Then you have to mention about the IV fluids and urine output. So this is in the C. In the D, you have to mention about the GCS of the patient, quickly assess that, and ask the pupils of the patient. And then there come the E part. In the E part, you will ask about the temperature of the patient. Now you have to examine the abdomen without depalpation. So open the dressing, number one, see if there is any stoma. This is important. They maybe have attached just the stoma bag to make sure that you know that the patient is having stoma bag. Sometime, because they may say that the patient has anterior resection and then stoma, and maybe a patient is having anastomosis distally. So temperature, examination, and don't forget to see the legs for DVT. Legs for DVT. And after that, after you have done these things, now ask the patient examiner again, what is the blood pressure now? What is the result of ABGs? What is the result of other bloods and blood culture? And what is the ECG findings and so at the end, ask the examiner, and the examiner will show you, okay, this is the ECG. What is the findings here? And you will say, okay, this is absent of P waves. So I would say that it is atrial fibrillation. Why patient is in atrial fibrillation? I think though because of the sepsis, this patient is in the if having atrial fibrillation. Okay, what is the blood pressure? Blood pressure now have improved. Previously it was 70/60. Now it is 90 and 60. So you will say, okay, it means the patient is responding. Responders, you know, there is patient categories: responder, non-responder, partially responder. So we say that patient is a responder. So I will give the patient now regular fluid and keep checking. What is urine output? Okay, urine output was nil, but now the patient is having in the last 30 minutes, their patient output is urine output is 25 mils. So you say, okay, I'm satisfied. Then what is the saturation? So you will say saturation, okay, it was initially 80 or 88, 85. Now the patient has saturation improved to 90, 95. So that is good improvement. And the heart rate coming down. You say ABG is okay. This is the ABG. This is showing that pH is low. It was 7.29. And the patient lactate was going down, and carbon dioxide was normal. So you say, okay, it shows metabolic acidosis, most probably because of the infection, maybe simple abscess, maybe because of the osmosis leak, maybe superficial site infection of the abdomen. So it can be because of the superficial site infection, abscess, and osmosis leak. So this can be, and then you will see the stockings, obviously. So next your viva. So your viva will be along with all these things. One thing I want to mention here specifically, that the examiner might show you the chart and you have to ask for the chart. Sometimes they show you the chart, sometimes they don't show you the chart. So you have to ask for the chart. This is particularly important. Why? Because if you have not seen the chart, it might be that patient has not received the normal analgesia post-operatively. That is why the patient was in the pain. Number one. Number two, might be patient has not received any fluid that was causing the low blood pressure, high temperature, high tachycardia. So that might be the reason. So that is why you need the chart. So what you have to see on the chart, this is particularly important, and I will make a separate slide for that, because there are two stations for you to assess for the chart. One for sure is the post operative, if the CCRISP comes to you in the exam. Second one is if you are having a phone call. There you have to see the whole chart of the patient, and there will be obviously whole of the chart. In those chart, number one, first thing you have to see is if the patient is having any anticoagulant or not. First and the most important thing. So write down, please, or you can take the screenshot later on. Number one is anticoagulant. Number two, in the see if the patient is having TEDs recommended there or not, right? So this is sorry. So anticoagulant. Number two, TEDs. Number three, see that if the patient is having a regular medication. Okay, regular medication. What will you see in the regular medication? If the patient is having, number one, analgesia. Number two, if the patient, for example, was having already COPD, if the regular medication charted, when I say regular medication, is that routine medication for the patient. For example, patient was previously having was on infliximab. Okay, so was the infliximab charted or not? Patient was heart problem, so bisoprolol. So see all the medication. Okay, so in this column, all the medication, and in the third thing, fourth thing, see PRN medication. PRN medication is the pain medication which is prescribed as required. So it is prescribed there, but it is administered as required. So for example, the patient was having some pain at the midnight. So you will not call the doctor to come and prescribe the medication. It is already charted there. The patient can take. So see this column. Fifth column, which is very important to see the IV fluids. So see that how much IV fluid was taken in the last 24 hours. And then you see urine output chart. Must see that how much is the urine output. And this is all you have to see in the cardex or the chart. So this thing, if the patient is having stoma, then you see what was the stoma output as well. In the last, sometime if the patient is having high output stoma, that can cause all these things as well. So you see all these things and ask the patient. So in this, I would add one more thing here. I can say SPO2, and you know the line for the when you switch to the CCRISP, I want to activate my team and attach high flow oxygen, pulse oximeter, cardiac monitor, two wide bore IV lines, and Foley's catheterization. And I want to take bloods for this, and including ABGs. Okay. So this is your first case for the CCRISP. I don't think so. I am left with anything here.
Sir, can we ask one question if you don't
Yes,
mind?
sure. Yes, sure. Now it is the
Okay.
time for the
Okay,
questions
thank you, sir,
one
for
by
your
one.
time. Sir, it might be a bit towards other side, as you mentioned that in phone call you have to also take the notes the same way. So, is it the same in the phone call notes as well that you have mentioned?
Uh, uh, Dr. Flan, thank you so much for the question. I'm sorry, I just distracted you guys to the phone call. Actually, what I meant was that to see the chart, only the chart. You have obviously the chart in the phone call station. You will be given two things. One will be the patient notes, and one will be the chart, where will be the patient vitals, patient's respiratory rate, news score, and all these things, right? So I was just mentioning that you have to see all these things there as well.
Okay, sir. If you don't mind, just talk about the phone call that might be a bit confusing for us. Like how there are, someone told me there are 9 pages. So how one have to compile those? If you could give a little bit idea about that.
Dr. Fran, thank you so much for your question. I'm sorry, but in this particular today's class, I will not go in depth of that case. Yes, later on you can discuss with me personally, or if you want, I think so. I have this lecture on my YouTube channel, so I can share with you guys as well, or I can arrange a separate class tomorrow for the phone call. Don't worry about that.
Sir, I want to ask when,
Thank you,
as you
sir.
said, you have to examine the legs for DVD stockings. Sir, I want to ask, should we just touch the legs or compress the legs?
Good question, Dr. Shoaib. So see if the patient is having TEDs and the patient is prescribed the Clexane. Clexane is the anticoagulant. So just press the legs. You have to press, not to touch the legs. Obviously, you see the tenderness. You press the legs and see at the same time at the face of the patient to see if there is
Sir,
any tenderness.
isn't it obsolete if the patient really have developed DVT? If we squeeze the legs, we will
That is a
definitely
different
close
test.
the
You
legs.
that is not that is Hoffman test. That if you squeeze it frequently, then it can cause. But you have to see obviously if the patient is having any swelling or the patient is having any tenderness. So then you have to see it. Yes, you have to see it.
We
Hello,
have to
sir.
examine both legs or just one leg,
Both
which
legs,
we
obviously. Patient, if there is both legs are swelling and patient is having edema on the both legs or the pain in both legs, it is least likely to be DVT, right? So you have
And
to
what
see
if the patient is wearing
yeah,
already
one by one,
TED
Dr.
stocking?
Shanza, one by one. So you have to see the both legs. If there are both legs are swollen, this is for your clinical as well. If both legs are swollen, less likely that the patient is having DVT. If one leg is swollen, this is also included in the Wells score. You remember Wells criteria for the DVT and pulmonary embolism. That if the patient is having both legs swollen, that less likely the patient is having DVT. So see the both legs. Yes, Dr. Shanza. Yes.
So what if patient is already wearing the TED stocking? Do we need to expose the patient and then do it?
No.
Hi, sir.
Yes.
Hello, sir. So thank you for this session. Dr. Shrenik here from Mumbai. So I've got my exam in Jan KL. So nowadays they are giving a lot of real patients in KL. So I'm basically a laparoscopic surgeon. And if you get this patient of incisional hernia, so you start your abdominal examination as per the routine, what we do for appendicitis or diverticulitis. And what other questions do they ask us in this? The incisional hernia. Do we have to do more examination or other tests, anything like that?
Okay, thank you so much, Dr. Shanik. Your question is
Yeah.
related to incisional hernia, right?
Yes, sir. Yes, sir.
Yeah, okay. I think at the end of this session, we have three scenarios today to mention. One
Okay.
is this one. Second is pulmonary scenario related to pulmonary embolism. Third one is related to abdominal examination. So I will explain this thing in the abdominal examination, if it is okay for you.
Thank you so much, sir. And sir, for the painless jaundice, nowadays they are adding this in the abdominal examination. So in the painless jaundice, the question and answer will go for the obstructive jaundice, that is for sure. But in the clinical examination, what do? We just do the Murphy's test and the superficial palpation and the liver percussion, all those things, or anything else besides that? For the
Obviously,
painless jaundice, sir.
excellent. Good question. If there is a patient with painless jaundice, obviously we will perform the same steps as we do for the other abdominal examination. So, but the question answer at the end will be different, obviously.
Yeah, it will go in the lines of obstructive jaundice, right, sir?
Yeah, yeah.
And while we're doing the superficial palpation, if the patient winces with pain, should we stop there or should take the permission of the examiner that I would like to do a deep palpation, but I will be very gentle.
Good, good question. Good question. So, if the patient is having tenderness in the superficial palpation and the
Yes, sir.
scenario is post-operative, it is clear cut that the patient is having. You have to switch toward the CCRISP, and you will mention to the
CCRISP.
patient that the patient is having pain. I want to switch to the CCRISP. But if you see that the patient, it is my third scenario today. For the other abdominal examination, pre-op abdominal examination, then you have to complete. I will explain this in the depth for
Okay,
sure.
sir. Okay. Thank you so much, sir. Can you please record this session, sir?
It
For
is
us
recorded,
to-
and I will share it on my YouTube.
Thank you so much,
Okay.
sir. Thank you so much.
Good as well.
Okay, I want to ask a question regarding the CCRISP. When we enter in the station and we know that it might be CCRISP, so we have to start from general physical examination by examining hands, pulse, and then pupils.
Yes, exactly. We have to start with the general physical examination, and then when you reach the abdomen, then you have to switch towards the CCRISP, not
So,
directly towards the CCRISP.
so in general physical examination, we need to expose the patient, like take off the gown in GP.
In GP, usually we don't expose. You can ask the patient to expose in the very start. Yes, I don't think so. This makes much difference. Either exposing at particularly the abdominal examination or the general physical examination, I don't think so. It makes much difference. But you must start with the GP, not start directly with the abdominal examination.
Okay, thank you very much.
Sir, I have a question.
Sure.
So what is the best time to ask for the charts if the examiner is not giving us the charts? Is it good to ask the charts before the starting of the examination or by the end we are finishing with the leg examinations?
So there was a good debate about 2 years ago about this thing, that when to ask for the chart, either with the start. So for me, and even here as well, the ideal thing is that we never go for the chart immediately. We first see the patient and then we see the chart. It is the routine as well. So I would say that go with all these things, and then when you see all these things, and specifically when you reach at the level of legs, then ask that I want to see the patient's chart to see the medication, the things I have mentioned here in my slide. So ask that I want to see the chart to see anticoagulation, TEDs, regular medications, PR and IV fluids, urine output, and if there is stomach output.
Thank you so much, sir. Thank you.
In abdominal patient has superficial tenderness. What about pulmonary? So after this, I will come towards the pulmonary embolism station. Is it clear now? Yes, Dr. Shanik. Okay.
Yes, sir. Yes, sir.
Okay, very good. So now we are coming to the next scenario, second one. So second scenario is related to pulmonary embolism. So just a second. My screen is visible to everyone, right? Okay. So now the second scenario. This scenario is a different one. So now the patient is post-operative day 8, day 10, like this way, post-operative day 8 or 10, okay? And the patient surgery was done, that was total hip replacement or maybe any pelvic surgery, right? Any pelvic surgery. So the patient is having this surgery, and after this surgery, now the patient, just a second. Now the patient has presented, patient is in the ward, and the either the nurse or the your junior doctor, they have explained to you that the patient is in severe chest pain. Number one, that is the severe chest pain. Number two is shortness of breath. So this is the second thing. And third thing is the patient is having tachycardia, heart rate is increasing, and blood pressure is decreasing. Heart rate, blood pressure is decreasing, and the patient's saturation is also decreasing. And there is no other cause that could be. So these are 5 things which the patient is having. So patient is having pain, shortness of breath, increasing heart rate, blood pressure is decreasing, and the patient has decreasing SpO2 as well. Okay. So this is the thing, and now the patient has come to you. So every person who will see, for example, even I think finally a medical student, if you mention to that guy, this is the patient, you say, okay, first thing I will root out if the patient is having pulmonary embolism or not. So this is the important thing first. Okay, right? So no, when you, this is the scenario outside. So this scenario straightway says that the patient is demanding you critically ill surgical care. So CCRISP. So this is the written on the scenario. First minute you see that this thing, and when you go inside the room, you see that the examiner is carrying a couple of charts there, investigations and all these things, maybe having X-ray as well, ECG chart, and other investigations, ABG's report, all these things. You quick look with your eye have on the table. Okay, this is, and when you see the patient is lying there, and the patient is having O2 mask attached to the patient. So this is the second thing, right? Sorry, third thing. The patient is wearing a O2 mask, and already the patient is attached with the high flow oxygen. So you see this thing. Third thing is that you introduce yourself to the examiner first, and then you go to the patient and say, hello, Mr. McDonald. Hello, Mr. McDonald. And Mr. McDonald is deeply silent, deeply silent. He is not talking to you. So listen to me again. In this station, patient will be attached with high oxygen mask. You go to the patient, you talk to the patient. Patient is not responding to you. It means this is not simple respiratory system examination. This is related to CCRISP. So now you have to go for the CCRISP, right? Understand? No. What are the steps in here in the CCRISP? So you are not going to ask the patient what's your name and date of birth and all these things. You will, after this thing, when the patient is not answering to you, immediately turn towards the examiner and say that my patient is critically sick. I want to switch to the CCRISP protocol. So now you switch to the CCRISP protocol. And when you switch there, now you have to see, okay, for the airway purpose, I need the anesthetist because the patient is attached already with the high flow oxygen. So now you will switch to the, you say, I need the sport, or they will say, okay, anesthetist there, what you want to do there? Okay, I want to see if there is any obstruction in the airway, chin lift, jaw thrust, all these things. Okay, you will say, and they will say, okay, it's done, done, done. You should know all the steps. So you will open the mouth, see the obstruction, chin lift, jaw thrust, and then you will say, okay, I want to put the airway, nasopharyngeal and oropharyngeal airways. And then you will say, okay, if it is not, patient is still not maintaining the oxygen, then I need for the intubation. But you will ask for the anesthetist help in the very start, because you don't know either you will be successful in managing or not. So you will ask in the very start. Other steps are same, like you will say, I would want to attach cardiac monitor, pulse oximeter, 2 wide bore IV lines, and high flow, and Foley's catheter. I want to take bloods for this, blah. And obviously all those things we have mentioned earlier, all those blood, ABGs. And then you will ask the examiner, okay, what is the heart rate? What is the, then after airway, breathing in the same fashion. But in this scenario, you have to auscultate posteriorly as well, because in the first scenario, we are not asking the patient to sit up. No one asked me why. The reason is that the patient is already having abdominal pain. If you are asking the patient to sit up, the abdominal muscles will be stretched and the pain will be increased. And you are not going to do that. In this case, the patient is having chest pain. The patient is not having abdominal pain. So you will ask the anesthetist or the examiner, can you please help me in sitting up the patient if the patient is lying down, because I want to auscultate the chest from the posterior aspect. So here the chest must be examined from the anterior as well as the posterior aspect, right? So after this, you will see airway, breathing, then circulation, same things. You will see the heart rate, you will see the blood pressure, and then you will see in this, then you will switch towards the D part will be the same. In the E part here, you have to see, number one is the site of the surgery. If it is right hip replacement, left hip replacement, you have to expose. The examiner may not allow you to expose, but you must mention it. Otherwise, you 100% will lose your marks. So say that I want to expose the site of the surgery. And once you expose it, then you will come to know that if there is any bleeding from that side, or maybe swelling on that side, or maybe something infection on that side. So this thing, and in the exposure things. So, and also you will see if the patient is having already the TEDs, and then obviously you will ask for the chart, cardiacs, same things. So what is the difference between these two stations? This is important. The difference, number one, that the patient will be post-operative day 8 or 10, not post-operative day 6. Second difference is the patient will be having a total hip replacement. The surgery will be different. Third thing is that the patient will be having pain in the chest, shortness of breath, heart rate, blood pressure, same thing, decreased oxygen saturation. Patient will not be responding to you, non-responder, oxygen mask will be attached, and you will immediately, before doing the GPE and all these things, you will immediately switch to the CCRISP. So here the GPE will be the same things as the part of the CCRISP. So you will go with the CCRISP, and then a high flow oxygen will be attached. You have to ask for the anesthetist and the external support, so that you can manage the airway, and rest of the steps are more or less same. The questions definitely will be different for abdominal examination and this respiratory system examination. Here they will ask you in details about the DVT, about the classification systems for the DVT and pulmonary embolism. How will you manage the pulmonary embolism? Which anticoagulant you want to use? How much is the dose? What is the definitive treatment? What is the definitive definitive what is the definitive treatment? What is the definitive investigation? So definitive investigation is obviously CT, pulmonary angiogram, CTPA, and the treatment, obviously you say anticoagulant. You need to escalate with the hematology department as well to see about the anticoagulant. They may ask that what other specialties you want to include. So obviously there will be the hematology. That's the important one. So that is all about this station. Now the questions.
Sir, like as you said in the previous abdominal surgery station, we have to do GPE examination first and then shift to the CRISP. So in pulmonary embolism case, do we need to do GP and then shift to the CCRISP, or suddenly start from the CCRISP and in the end we will do GP?
So GPE here, as I mentioned clearly, that here the GPE will be part of the CCRISP. So you will be doing the same things like taking the pulse in the part of respiratory, in the circulatory system, and checking the hands and all these things. This will be part of the CCRISP. So you don't need a separate one. One thing I did mention shortly, but not in detail, to see in the cardiacs, that is about the news chart. You know very much, I think very clearly about the news, as I explained earlier. News is the National Early Warning Score that is done here in the NHS and HSC both. So it includes all these 5 systems. So news chart is a separate one. I have provided this to the class in the classroom as well. So news chart is like you see all the 5 things. Number 1 is the respiratory. In the respiratory, you see about that the patient respiratory rate, what is the saturation, if the patient is on oxygen on the room air, and how much oxygen is the patient on. And similarly, in the circulatory, you see the heart rate and the blood pressure. Then you see the temperature of the patient, and you see the ACVPU. So you see all these things. Yes, next, please. Next question. Yes, Dr. Wes. Your mic is off.
Sir,
Dr.
what about consent?
Hello.
Dr. Wes.
If the
Dr.
patient
Wes.
is not responding. Okay.
Hello. Can you hear me, sir, now?
Yes, please.
Okay, so I want to ask that you have told us that we should examine the patient from the back in the sitting position. And as the patient is intubated and unconscious, so should we ask for the sitting position, or should we ask the patient to in the left lateral position for the examining from the back?
Good question, Dr. West. Good question. Very good question. So you can ask, see what is feasibility. You can see
Yes.
the patient in the better to see in the sitting position. If the examiner asks you what is the other option, then you can mention that I can do it the left lateral or right lateral. Okay.
Okay, so we should first mention that we should
Obviously,
examine the
in the
patient
sitting
in the
position.
sitting position.
Yes.
Okay, okay. Thank you.
Next, please.
Can I ask you a question, sir?
Yes, yes.
Sir, what about consent if the patient is non-responder in this scenario?
No need of any consent here.
Okay.
The patient is dying and no need for consent. Go and save him.
Okay.
Next. Yes, Dr. Shah.
Thank you, Dr. Zulkarnain. I have a question. Sorry, can you repeat the point where we will shift from the GPA to the CCRISP? Someone asked in the comment as well, so I missed that part. Thank you.
In the first case and the second case?
No, in this question, in this scenario, the pulmonary embolism.
You will not go with the GPE at all.
Oh, okay.
We will not do GPE. See, I explained to you again. You are going to the patient, you start the questions, the patient is not responding to you at all. You will immediately shift yourself to CCRISP. Right? There is no need to go first with the GPE and then go towards the rationale here is that the patient is in critical situation. So the GPE will be part of your CCRISP. So you will not be like the patient is. So tell me, what is the what is the sequence of CCRISP?
Is the ABCDE.
ABCD. So here the patient is already having a problem. So you will first fix the A problem, right? A problem. And then you will go with the B problem and the other ones. So what are you going to see in the GPE first? You always see pulse and then the fingers and then these things and then you go with these things, right? So you will not do these things first. First, you will fix the airway, followed by other things, right?
Got it. Thank you much, Dr.
Oh, thank you. Next question.
Well, if the patient is having severe pain and having severe shortness of breath and having stridor, so do we need to ask for the anesthetist's help in order to protect the airway, like passing the oropharyngeal airway or nasopharyngeal airway?
What is the other option?
So do we need to involve the anesthetist or do we need to do by ourselves, like jaw thrust and chin lift?
Obviously, what you will do, you will ask the examiner to that I need the anesthetist help, and you will start yourself managing the airway.
Okay.
So it is not a vertical. It is not the vertical. It is a horizontal way. So you will be starting. You will see the airway. You will be starting with the open the mouth, starting the airway, and meanwhile, you will ask the examiner, I need the help of anesthetist to fix the airway, right?
Okay. Thank you.
It is a horizontal. The CCRISP, ATLS, both are horizontal. Horizontal means parallel. one person is doing one thing, second person is doing other thing, third person is doing other thing. This is the horizontal. The vertical method is one person is doing one thing, and once he is finished, then the other person will start the other thing. So this is not the vertical. This is the horizontal, right?
Okay, thank you very much.
Next question. Okay, guys. Now we will move to the third and one of the very long. Yes, Dr. Nimra, you have the question.
Yes, sir. Hello, sir. Can you hear me?
Yes, yes.
Sir, I want to ask while doing the first scenario of the examination of abdomen, either I need to examine the chest or abdomen, or I need to remove the dressing first. If there is a dressing when I expose the patient.
You are exposing the patient and there is a dressing.
Okay, yes. Then I need to examine the chest or abdomen first, or I need to remove the dressing and then look for the dressing first.
So you are going to inspect the patient, right?
Yes.
So do you want to inspect what is under the dressing or not?
Yes.
So obviously you will do remove the dressing, and then will say that you will ask the examiner, I want to remove the dressing, and 99% of the time the examiner will say, okay, consider it is removed, right?
Okay, then I'll shift to the examination of the abdomen.
We will start the abdominal examination. Yes.
Okay. Thank you, sir.
Yes. Yes. Is it clear?
Yes, sir.
No, it is not clear. That's why I asked. So you will go, and after you have finished your GPE, you expose the patient. There is a dressing on the patient abdomen, and you will say to the examiner, I want to remove the dressing. Can I? So examiner says yes, remove the dressing. He says no, consider it is, and there is a laparotomy scar underneath. Most of the time they want to say what you want to see under the dressing. You say, I want to see if there is laparotomy scar. I want to see the wound. I want to inspect the wound. And then they'll say, okay, there is a wound inside and wound is fine and healthy. They ask that why do you want to see the wound? I want to see if there is infected wound or the normal wound, right?
Okay.
And then you will say, okay, you do the inspection. After inspection, you start with the superficial
Palpation. Superficial palpation.
Now
Okay,
it is
sir.
clear. Now it is clear.
Yes. Yes, sir. Now it's clear. Sir, I want to ask you one other question. What we will do for the removal of oxygen mask before examining if the patient is attached with oxygen mask? So how could we examine the airway then?
If the
Do we need to remove the airway?
you mean that in the second
Yes.
scenario,
Yes,
the
sir.
patient, the oxygen mask is attached, what you have to do, obviously the patient will not be having airway, right? 110%,
Yes.
right?
Yes.
You will go and you will gently remove the airway, okay?
Okay.
And you will try to open the mouth, and the examiner will say that okay, it is considered it is open. What you want to do, you say, I want to see inside the mouth if there is any obstruction, is there any
Only
bleeding
foreign
and
body.
anything like that, foreign body and all these things. And then okay, there's no foreign body, you will put the mask there again with the oxygen, and you would say that I want to see as well if there is high flow oxygen attached. Okay, it is high flow and running, right?
Okay, sir. Okay. Thank
Okay.
you, sir.
Okay, now
Okay.
coming
Got
towards
it.
the third scenario, that is also extremely important. They come more common as compared to the other one. Just a second, let me put a scenario in the group.
Excuse me, sir. Can I ask you a question in the meanwhile?
Yes.
So in either of the scenarios, in three of these, if the patient is of opposite gender, do we have to offer a chaperone during examination?
Yes, obviously. But they will never put an abdominal or chest examination of female patient. Remember.
All right. But we can offer for the if the patient is
Obviously,
male.
you have to, not can. You have to.
All right. Thank you.
Sir, can I ask a question?
ahead. Hello? Hello?
Yes, doctor.
You know when was call finished? I don't know.
It's still the same one.
Sorry?
The same call is going on.
No, but when it was like,
We're supposed to start the third case.
so, okay. Oh, I am speaking for the last 20 minutes.
We didn't hear from you. We are waiting that you are going to start.
Oh my God. I am finished. I'm sorry, guys. I will start it again. Sorry. Sorry. I was speaking for the last 20 minutes. I don't know why the call was like, how did it happen? So let's start. I'm sorry, guys. See here, I have finished my whole of the. Okay, so there is a third scenario. Third scenario will be related to sorry, let me message in the group. Okay, you can listen me now. Hello? Okay. No.
It is echoing, sir, of your voice.
What's happening?
Still echoing of the voice.
I don't know if I need to cancel the call and then maybe, yeah.
Sir, it seems that you are live from two accounts.
Is it okay now?
Dr. Zulkarnain, I think mic on your laptop and phone is both on.
Just a second. Is it okay now?
Yes, now it's okay.
Yeah, just a second then. Okay. Yeah, it's fixed now. Perfect. Let's start. Sorry, guys. For 20 minutes I was speaking. So, third scenario. There are three scenarios. Let me start the recording for this one as well. So, there are three scenarios. Third one, we start it now. So you have a scenario for the right iliac fossa pain, left iliac fossa pain, right upper quadrant pain, inguinal hernia, and senior hernia or jaundice. This is the most common questions which come in the exam rather than the CCRISP. For example, if CCRISP is coming one time in a year, you people get frightened that this is a difficult case that came in the exam, and you start preparing for those. But these questions are coming more frequently nowadays. So there is one concept which I want to clear specifically, and I don't know from where this concept particularly came. That is totally actually rubbish. That if the patient is having right iliac fossa pain, then you should not palpate the right iliac fossa. Similarly, for the left iliac fossa of the right upper quadrant. I have been trying to clear this concept for the last 3 years, but it's still present in some cohort. So, if the patient is having right iliac fossa pain, many of you guys are senior to me, and they can confirm it as well. For example, if the patient lands to you in the emergency with the right iliac fossa pain, so will you go for examining the patient and examine the right iliac fossa as well, or you will just leave the right iliac fossa there and will say, okay, I have examined the other parts of the abdomen, there is no pain, and the patient is saying that the patient is having right iliac fossa pain. So according to the patient's report, I would say that the patient is having acute appendicitis.
Sir, can I answer?
Yes, please.
Yes, sir. So I am a laparoscopic surgeon from last 17 years into practice. And so in a patient with acute appendicitis, you definitely would start with the RIF examination. You will start on the left iliac fossa, and then you come towards the right iliac fossa, and you do all the maneuvers like the Rousing signs and the Suarez sign, all those things. So you will definitely look for the rebound tenderness, and you will be very gentle. And for palpating the right iliac fossa, you need to see whether the patient is having guarding rigidity, or the patient is having an appendicular lump. So if you could palpate appendicular lump, your entire treatment changes. So then you might go for an osteoarticular regime and conserve the patient.
Exactly.
So definitely, yeah.
Exactly. That is my point. So so there was a concept, I don't know from where did it come, that if the patient is having right iliac fossa pain, I will not touch the right iliac fossa, the left iliac fossa, or the right upper quadrant. But it is totally rubbish.
No.
In the exam, if you're not doing this, you're losing your marks. So what you have to do, same things, all right, for the abdominal examination. Go introduce yourself to the examiner, introduce yourself to the patient, take the consent from the patient for the examination. Say that I would go first with the GP, expose the abdomen, and after you expose the abdomen, do with the inspection first, followed by palpation, and the palpation in the standard way. Standard way means, for example, patient is having a right iliac fossa pain, you will start from the left iliac fossa, go upward, and then coming towards the right iliac fossa at the end. Similarly, for the left iliac fossa, start from the right iliac fossa, and the right upper quadrant, you start from the left iliac fossa, and then go towards that particular area and do all the maneuvers, whatever you want. For the inguinal hernia and inguinal hernia, this is particularly important. These two are important, and I want to take some time for these as well. So for the inguinal hernia, first you will do general physical examination and then you have done the inspection. So once you are finished with the inspection in the lying position, then you will ask the patient to the standing position. If the patient is sitting, straightway from the sitting to the standing position. So inspection in the lying position and then followed by the standing. In the standing position, obviously you will expose the genitalia and you will examine the patient first from the front and then from the sides as well. And then you will palpate the area. So palpation in the inguinal hernia will be in the standing position, right? So in the standing position, you will see, examine that particular area. Where is the swelling? What is the upper end? Where is the lower end? Skin and everything. You will do it. And opposite area first, opposite side first, and then the right of the left inguinal area. And after that, you will do the, after inspecting and palpating the swelling, you will do the genitalia examination. Genitalia examination is extremely important. Okay, so genitalia examination is extremely important. So you will see the testes, both scrotum, you will see the penis, position of the penis, urethra. So these are 3 to 4 things which are important. And after that, you will ask the patient to lie down, and then you palpate a whole of the abdomen, also including the para-umbilical hernia region. Para-umbilical hernia, umbilical hernia region. Umbilical, para-umbilical, you have to see in the standing position as well, and then in the lying position. And then at the end, you will say, I want to perform the digital rectal examination. For the inguinal hernia, same things. First, in the lying position, if the patient is lying. If the patient is sitting in the chair, then first ask the patient to stand up and you see the swelling, and then you ask the patient to cough and do the maneuvers and see. And then you ask the patient to, if the patient is lying down, then first examine the patient in the lying position, inspect the abdomen, but palpation again in the standing position. So ask the patient to stand up, to cough, and see where is the inguinal hernia, see the defect after reducing it, and see the other hernial positions like inguinal hernia positions, right? So other hernial orifices. Genitalia in both things. And then at the end, you ask the patient to lie down, do the whole of the abdominal examination. In both cases, in both these cases, don't forget to see for the surgical scar marks. Surgical scar marks. So this is important because it may be recurrent incisional or inguinal hernia, and there is 99% chances the patient in both incisional and the inguinal hernia will be the real patients. Okay, so this is important. This is important. So because you can see the patients in the wards as well. So for the inguinal hernia, do the inspection in the lying position, followed by palpation in the standing position, including the genitalia and para-umbilical hernia. Then and also then ask the patient to lie down, and don't forget to do DRE in both patients. Okay, in all the abdominal examinations, DRE is important. Okay, except in the CCRISP. In CCRISP, you won't do that because the patient is critical. Jaundice. Jaundice is standard abdominal examination. So you will do a standard abdominal examination, including all the things. Okay, so if the patient is jaundiced, see the standard abdominal examination positive finding might be sometime palpable gallbladder. Palpable gallbladder might be a good finding. In that case, one thing which I want you to remember is for this patient in the uh, obstructive jaundice is to see if the patient is having cachexia, right? If I'm not wrong, the patient, the spelling is right. Okay. Cachexia, number one. Number two, if you see if the patient is having some secret marks coming from the itching. So in the jaundice patient, these two things never forget. Okay. Ask the patient about the anorexia and the weight loss as well during the um, examination, and see these two things. And at the end, do mention about the digital rectal examination. Why digital examination? They will ask you in all these cases that why digital rectal examination. So here in the jaundice patient, straightway answer is that might be some colorectal carcinoma that is having metastasis to the liver that's causing the jaundice. Incisional hernia is that the patient might be having some obstruction, might be having some mass, might be having fecal loading and causing a recurrent constipation, and that can cause incisional hernia. Same in the inguinal hernia. So you have to you tell them that why are you doing this digital rectal examination in this patient. Similarly, in the right upper quadrant pain, you can say that I want to see if there is any mass problem with the prostate. So here the prostate, inguinal hernia and senior hernia, you have to mention about the prostate as well. So prostate, and the number one is the prostate, and number two is the any mass. So for the right upper quadrant pain, same. If there is any mass in the rectum, and in the left eyelid fossa pain, you can say that I want to see if there is any fresh pee or bleeding. This is important, okay, for the left eyelid fossa pain. Why? Because if the patient is having just bleeding the verticulosa, then might be fresh pee or bleeding. So this is about the abdominal examination. Then you have obviously the questions related to this and the answer. CCRISP station will be for 9 minutes, but the abdominal examinations will be for 6 minutes. One thing is that, yes, this is important as well. Sometime with the left iliac fossa pain or right iliac fossa pain, or the right upper quadrant, if the patient is having a cholangitis, they give you the chart and the ECGs and these things, and then the candidates come and then say that, sir, there was patient pre-op patient, and that was CCRISP. So remember, if the patient is coming to you with the like this way, this is not a CCRISP. They are just giving you the findings on the charts or maybe on the labs that, okay, this patient is having this ECG, or this patient is having this ABGs, or these are the bloods. So just interpret what is this. So this is not the CCRISP. Sometimes, for example, if the left iliac fossa and the patient is having diverticular abscess, okay, so now the patient with diverticular abscess, Dr. Sadir, your video is on. Please turn it off. So if the diverticular abscess, they can give you that the patient is having ABGs where it's going acidosis, or the patient is having serum lactate that is high, or the patient is having WBC is high. So interpret it and just tell us that about what is the treatment options. So this is not related to CCRISP. This is just simple questions related to that station, right? No questions, please. Yes, Dr. Shahzad.
जी सर सर in inguinal examination, we straight away ask the patient to stand up and have an inspection, or we should move firstly towards the general physical examination by looking the hands and eyes, and then ask to stand up the patient.
General physical examination, inspect the abdomen after the exposing it, and then ask the patient to stand up.
Okay, sir. Thank you.
Because you are exposing the patient, including the inguinal region, and you want this exposure as little as you can. So you don't want to expose the patient first and then do the GPE, general physical examination. So general physical examination, abdominal examination, inspection, followed by asking the patient to stand up. And once the patient stand up, then do the genital examination, and then ask the patient to lie down.
Okay, sir. I have one more question. In case of acute appendicitis, when you are doing palpation, you would do the specific tests like rebound tenderness and Rovsing sign and other tests in it, and then move to the other examination, or will
What other examinations?
other like shifting dullness and
Why do you want
percussion.
to do shifting dullness in acute appendicitis?
I think so. We have not. Don't do to. I think, sir. We need not to do it.
Yeah, I think I mentioned in the last lecture as well that when do you do shifting dullness?
Okay, sir. In case of hepatomegaly or splenomegaly or like obstructive jaundice or other cases like that.
When you see that there is ascites, when you feel the ascites, when you go, you are doing the percussion, you come to the hypogastric region around the epigastric, around the umbilicus, and you feel there is some dullness, and then you see, okay, I want to see that where is that dullness, where is. So if you, why they will put patient with ascites to you in the exam. So don't worry about this one, that the patient with appendicitis, the patient will not be having ascites.
Thank you, sir. Thank you so much. Thank you, sir.
Yes, next is Dr. Nimra Chaudhary.
Sir, I read somewhere the question that examine the chest and the patient is having trauma to the clavicle, and somewhere it was the patient is having trauma with football and examine the chest. Then what we have to do, is it ATLS what we have to do in examination?
Repeat the scenario.
Sir, I don't know the whole scenario. I read in the past question that were shared recently that there was a examination station, examine the chest with clavicular fracture.
So it depends upon the scenario. If they're saying that the patient is having, recently the patient came to you with the, like the patient is having roadside traffic accident, landed to you in the emergency, and now the patient is having clavicle fracture, and examine the patient. So obviously you have to go with the ATLS 110%, right?
Yes,
If
sir.
they say the patient was having previously some time injury and now the patient is having that clavicular fracture as well, and you have to examine the chest, that is a different scenario.
Okay, sir. And then, sir, in ATLS, we have to do the same step like
If,
secret.
no, CCRISP is different than ATLS. In ATLS, you have to, I haven't heard any of the station coming as ATLS in the exam, because ATLS is like a big thing. So ATLS will be like, first you will ask to secure the airway and to secure the spine, cervical spine, and then you will move towards the ABCDE, and then you will be having whole of the team. You will end up with the log roll. So ATLS steps are different as compared to CCRISP. There are
Okay,
some similarities, but difference.
it means it routinely not come in the exam
No,
during.
no, I haven't heard. If it is there, I cannot deny. The I'm not 110% updated, and but I haven't heard about ATLS in the last 3 years, at least.
Okay, thank you, sir.
Next is Dr. Nimra Chaudhary. Okay, Dr. Shuaib Adris.
Hello, sir.
Yes.
Sir, I want to ask you a question. If examining acute appendicitis in abdomen, so in a deep palpation, like sorry, in organ palpation like spleen or percussion of the spleen, we have to start from right iliac fossa. So one question is this: how will start the percussion and palpation of the organs starting from right iliac fossa? And other question is, we have to do the acute appendicitis specific test, clinical test at the end or at the start?
Very good question, Dr. Shiv. Very good, logical questions. So your first question that you have done the palpation, deep palpation is done for the abdomen. You feel that there is acute appendicitis. You have so when you feel that there is tenderness in the right iliac fossa, go for the deep rebound tenderness, Rovsig sign straightway, right?
Right.
Straightway. Why? Why? Two things. Number one, you will be confirming the diagnosis straightway. Number one. Second is, if you start, for example, examining the other things, genitalia and organomegaly and all these things, you might end up without without performing the important test like rebound tenderness and Rovsing sign, right?
Right.
So better and 100% recommendation is that that you examine the right iliac fossa. When you examine it, there is tenderness, go for rebound tenderness, Rovsing sign, and then you come up with the organomegaly and other things. Second question, that should I how should I do the percussion and the palpation if the patient is having, for example, spleen or the liver, because you have to cite. Obviously you are not going to start from the right iliac fossa 110%. You will start with from the umbilicus or near the umbilicus where the patient is not having any pain, right? And you will start palpation from there, and then you will go up, going up, and percussion you will do only if there is you feel something, and then you have to confirm it, either it is pure organ or there is just I am not sure about that. So then you do percussion for the organomegaly, right? You don't do percussion for everything. Okay,
Sir, one more question.
Sure.
Sir, if there is acute appendicitis, let's suppose, and you have done superficial palpation and deep palpation, and there is no organomegaly, there is no shifting dullness. So you just go for superficial palpation, deep palpation, and special test for a clinical test for acute appendicitis, because there is no organomegaly. You are not going to percuss. There is no shifting dullness. There is no ascites. You are not going to test for ascites, and of course, you are not going to percuss for liver again. So the examination is become very short, no? How can we?
Are you sure you finish this examination within 6 minutes?
I'm not sure, but if I'm limited, to just
listen. You are doing the inspection from the right and the left side. Oh, sorry, right side and the foot side. Number one.
Right.
You are seeing the respiratory rate as well. General physical examination 1 minute, inspection, and then your superficial palpation, deep palpation for that particular organomegaly, for the liver, for the spleen and the kidneys, and then you are going to do the percussion and then auscultation, and then you are going to see the genitalia as well. and you are seeing the lymph nodes in the axilla and the neck as well, and you're seeing the genitalia as well, and then you, so it will, so leaving only the percussion you will not do if there is nothing palpable and nothing doubtful. You are not going to do percussion. For ascites, you are going to start percussion from the epigastrium up to the hypogastrium, and if you are not feeling any dullness, there is no point in doing the shifting dullness.
Okay.
Yeah, shifting dullness means there is dullness that have been shifted to other side. But if you don't feel any dullness, why are you going to do the shifting dullness?
Okay, sir, but last question.
Sure, why not?
Sir, in every abdominal examination, we have to examine genitalia, inguinal lymph node, cervical, axillary, cervical, and inguinal, and genital examination.
Yes, abdominal examination, obviously. You cannot escape the lymph nodes in the neck, in the axilla, and there was one more in the inguinal region, and you cannot skip the genitalia and the DRE. If you are skipping marks.
All right. Otherwise, if there is a less time, now this is the less time again. So we have to mention this thing in presentations.
Yep.
We are
If you're not presenting, you are reducing your marks yourself.
Okay, sir. Thank you.
Next, please.
Hello, sir. I want to ask you, what's the, you told us that we also might the station cholangitis, and there might be the charts are also present over there. How would we differentiate either it's a CRISP or not? Could you please elaborate a little more?
For the cholangitis?
For cholangitis and CRISP. I want you to please elaborate a little more between the.
So if there is pre-operative case, you have not to perform the CCRISP in the exam.
Okay.
Yes.
Sir,
yes.
One question.
Yes, please.
Sir, in respiratory examination or in CVS examination, we have to calculate respiratory rate for 1 minute
30
and
seconds. 15
yes,
or 30 seconds. 15 or 30 seconds.
Sir, can we wear watch or we have to look at the wall for time?
I don't think so. Watch is permissible there. So there will be one in the room. So you have to look at that.
All right. Sir, from history taking, I have one question in MMSC and dementia.
Rather
if you
we will
don't mind.
cover tomorrow. Rather we will
Okay.
cover. No, I can answer you in. You can send me the question. I will answer you 100%. But we are going to cover this thing in details.
I can understand.
So yeah, you can send me the question. Sure. Must
thank
send
you.
me the question, please. I will, and I will share you to the others as well. No worries.
All right.
Yes. Any other question? Yeah, there was some question in the chat box. Sorry. ATLS steps. I have heard about a similar scenario. Dr. Rehan, if you share me the scenario, I can find out. For the ATLS, I can do a separate class for all of you without any cost. I can arrange one good class for all of you. Yes, I can. But if you share me the scenario, then it will be good for everyone. You just share me a scenario with me, and then I can do a separate class for this ATLS, then AMTS and MMSC. For these, I know the difficult things. Tomorrow, I can do it tomorrow. No worries, because it will take obviously another 2.5 hours. Rehan, I will be thankful to you Dr. Rehan and Dr. Nimra. Next question. Okay, guys. Thank you so much for your part. Yes, please.
Sorry, Dr. Zulkarnain, to interrupt you. I have a question regarding the both scenarios for CRISP and the abdominal, the normal examination. If patient is post-operative and is having a blood transfusion, and the patient, the nurse asks you to examine the patient because he is short of breath. So, do we have to perform the CRISP or simple the pulmonary embolism examination thing?
No, you mean the patient post-operative? No, what is the scenario? Like a simple.
Yeah, the scenario of blood transfusion reaction, and he's having allergic reaction to the blood. So, do we have to perform the CCRISP or the simple examination?
We have to see if the patient is stable, saying that the patient, you go inside, the patient is totally stable. Then you have to see the chart and no need to perform CCRISP. Just perform whatever examination they have told you. If you feel that no, they have mentioned the patient is sick, respiratory rate, everything is high, and this, all the findings I mentioned earlier, so you have to perform the CCRISP. Yes, sometimes the patient is having trolley related to blood transfusion, and then the patient can have respiratory complications, and patient can be serious. So you have to perform in that case. In that case.
Sir, one question.
Yes.
Sir, recently I have heard that there is a examination like carotid endarterectomy have done, and now go and do a relevant examination of the cranial nerves. Can you please elaborate about this scenario? And on examination, someone sorry. On examination, someone told me that there was a deviation of the tongue to one side, to the side of injury, hypoglossal nerve injury.
Yes, if there is carotid endarterectomy and you are asked to do the nerve examination, I always mention about the nerve examination first, that first do the relevant nerve examination. For example, if there is carotid endarterectomy, what you will first see?
So last four cranial nerves. Hypoglossal nerve, sorry.
Before that.
Sorry, sir?
Before that.
Inspection.
Inspection. So on inspection, what you will first see? First thing to see. Where is the scar mark?
Yes.
That is the first thing you will see. So where will be the scar mark?
Sir, on the below the mandible, on the left side of the left.
Excellent. Which nerves are there?
Sir, vagus nerve, hypoglossal nerve.
Seventh nerve.
Seventh nerve, yes.
Marginal mandibular branch of it.
Yes.
Marginal
mandibular. So
lingual nerve.
Lingual nerve.
Yes, exactly. Lingual nerve, vagus nerve, all these. So you will start with you will skip 1, 2, 3, 4, 6 first. So you will first go with the fifth and 7, 8 you can do. It is with the 5, 7, 9, 10, 11, 12, and then you will come towards 1, 2, 3, 4, 5, 6. Right?
All right.
So you have. So
5, 7.
This is a good scenario with that. Yes, just a second. This is a good scenario with carotid endarterectomy. This is a good scenario. What other things you will see in carotid endarterectomy?
Sorry.
What other things you will see in carotid endarterectomy?
So I don't know, sir. Sorry.
Is there any tongue deviation and obviously these things? Then you will see the scar mark. Is there any bleeding from the side? This is very important.
Yes.
Okay. This is very important. And why are you going to examine the other cranial nerves?
Sir, they are related to the.
No, they are not related to the procedure.
But they are in a field, like in a surgical field, like carotid endarterectomy.
No, this is because why are you doing carotid endarterectomy?
Sir,
Why?
could be in coordination or balance problem,
because there is carotid stenosis due to atherosclerosis, and
yes.
there is chances of ischemia. So after even endarterectomy, you are not 100% sure that the blood supplied to the brain is stored, is restored or not, right? So you want to examine those nerves as well.
Sir, 5 and 7.
All 1, 2, 3, 4, all other nerves. I mean, after this,
All right.
there are
So first we start with the which nerve? 5, 7 or from 12?
whatever you want. It is totally
All
up to you. Make your own arrangement. But better to go with 5, 7 in a sequence. Better to go with the sequence.
Thank you.
Okay, next question.
Sir, can I have one question?
Sure, why not?
Yes, sir. Actually, sir, thank you for conducting for us this lecture. Sir, my question is during examination of optic nerve. First, we should start with visual acuity. We should be away from the patient 6 meter and show the patient a snell chart and ask the patient which the last line you can read, right?
Yes.
But sir, my question, should we bring with us this chart or this chart already will be provided?
You have not to bring anything with you.
Oh.
Anything with you. That Ishihara chart or this chart, they will be present there already. Okay?
Yes, sir.
So you need not to do this thing.
Yes, sir. Thank you, sir. And sir, another question is during sir visual field. Visual field, should we examine the patient both? Yes, of course, right and left eye. Should we examine temporal side and nasal side, or only just temporal is enough?
Both sides, both sides.
Yes, sir. Like, sir, I asked this question because in a nerve examination, it's a long station. That's why.
About the eye examination, optic nerve examination, is it? Yes, Dr. Shir.
Sir, my question is, there are some examination like in hand or in shoulder examination. We have to do on both sides. If it's mentioned over, if let's suppose right side mentioned, so we have to compare both sides, or only we have to stick on the right side.
Both
The
sides. Both sides. So mention to the examiner that according to the rule, I should examine the normal side first. Do you want me to examine the normal side first or the abnormal side first? If he says normal side first, go with the normal side first, do the abnormal side then. If he says no, do only on the abnormal side. And most of the time they say the same thing. So go with the abnormal side. Okay?
All right, thank you.
Okay,
Hello.
guys. Yes, Dr. Shivani.
Dr. Zulkarnain, I have one question. Like when we are doing in the CVS examination, and if we found a murmur while the auscultation on the either the mitral area or on the aortic area, first we need to auscultate that with the bell of the stress, and then with the first with the diaphragm and then with the bell. No? So if we found the murmur at any point, we tell the patient there and there to change the position to whether it is get exaggerated with it or not.
Yes, we have to see the we have to change the position accordingly.
Okay, so if we are like going for the auscultation and first we are going in the aortic area and we suppose found the murmur is there, then we ask the patient to lean forward and take a deep breath and hold it so we can hear it, we can hear its loudness. And then we will go towards the neck and then we will go towards the rest of the areas.
Exactly.
Okay.
100%, 100%. So whatever you have the finding, first confirm that finding, then move to the next thing.
Okay, thank you very much.
Okay.
Yeah, and Dr. Zulkarnain, I have the two more questions regarding the procedural skills. If you allow me, I can ask that as well.
Yes, you can, Dr. Shivani.
Okay, so regarding the FNSE station, there are basically the two methods of the FNSE. One is with the plunger that we don't use here in the backside.
FNSE is excluded.
Okay, and one other is regarding the blood cultures as well.
Blood culture is also excluded.
Okay, then
This
that's
is
fine.
for the plab, not for the. Don't do the extra things. Focus on the main things, right?
So, on the procedural skills, we have to focus on the nevus excision, access drainage, knot tying, the suturing, and if there is a chest drain insertion station might be there, and the catheterization.
Yes, if you have seen my video lecture for the procedure skills, I have mentioned all those 8 stations. And there are 8 stations, 6 or 8. So
yeah,
only those stations.
Okay. Okay, thank you very much, Dr.
Thank you so much. Any other question, please, guys? Okay, guys. Thank you so much. I will share the recording once it is there. Yes,
Dr.
that's
Zulkarnain,
fine. Yes.
I have one more question. I just wanted to confirm that I have to practice the double-handed reef knot, the single-handed, and the surgeon's knot, the slip knot, the instrument tie, abundance knots, and is there anything else that I need to
No
practice?
need for Aberdeen. Who asked you for Aberdeen knot and
Okay. So just these 5 knots are enough.
That is Shivani, I want to be your student. No need for just instrument knots, single-handed, double-handed reef knots, and these are important. Slip knots, depth knots. So these are important. These are not.
Okay, and regarding the suture technique, there is like the simple suture, then there is vertical matrix, horizontal matrix, and the figure of 8 mostly coming.
Figure of 8 is important, most important.
Yes.
Figure of 8, right?
Okay.
Thank you so much.
Thank you very much.
Can I have one question, sir?
Yes, sure.
Sir, last time I have given MRCS, and over there, the figure of 8 skewering skewering suture. So there was just a dot over there, and there was no like incision or any sharp injury on that dummy. Also, I just passed the needle one by one. I suppose that point is the incise part that they have marked, like a red point. They have shown over there, and I passed the needle one by one. So, is that right, or should I have to pass through both edges?
No, one by one means, what do you mean by one by one?
There was no proper incise cut, but there was just a mark with the red pen. And they said this is your area, and you have to make a.
So there was a dot and there was a line, right?
Yeah, there was a dot.
There was a dot and there was a line as well, right?
Yes.
Yeah. So you have to do the figure of 8, just like from one end to the other, and then so it should be on the both sides. For example, it will show you with the screen. I think I should share my screen and then show you here.
Thank you.
Better explain to you guys. This is a good question, Dr. Shiv. You are coming with very good questions.
Thank
you. Just a second. So, for example, they have shown you that this is the dot. For example, there is the bleeding, okay, and they're showing you, okay, and then they show you that that this one is this is the line, right? For example, they say that this is the incision, for example. So what you have to do, you will go from here. This is your number. Just a second. So this is your. So you will go from here to here. That will be your first. So from here, this is your first, and this is your second, and then from here you will go here 3. So you'll go from here towards this way. This is your 3. So, and then from here you will come towards this way. This will be your 4, and then when you will knot it, it will be knotted like this way, and it will be figure of 8.
All right, sir. Knot should be on the first. Knot should be on the suture, or no, sorry, on the inside part or on the side.
So if you are coming here, it doesn't matter on which side it is the knot. So it doesn't matter either it is on this side or knot is on this side. It doesn't.
But it
matter.
should not be on midline.
Yeah, it should not be midline. Yep. Yeah.
Right, sir. One question, if you don't mind. You have drawn a green line. This is showing the inside part. So we
Yes.
have to take from one side, and we have to take it out through the green line. Then again we have to take from the green line and
So-
take out from the point 2.
So what happens in real? What happens in real? For example, I show you.
So we have to take that proximal as well as the distal control. I guess
Yes.
that's what he want to ask.
Exactly. So for example, this one is the bleeding part. For example, here is the blood vessel that is bleeding, and you don't know from where it is coming. So what happens naturally is that you will be having 2 edges of the incision. So for example, here is the bleeding. So you will be having one edge here up, and other edge is usually here on this side. And you don't know from where is the bleeding, from where is the blood vessel coming, either coming from here, here, here. You don't know. So normally what happens naturally is you are coming from this edge, from this side to this side, and then you are coming from this side, and then you will knot up, and whatever the vessel here it is, that will be tied up. So that is the concept behind this figure of 8. So one thing is that is most important is your stitches, both of your stitches should be on the both sides of that bleeding point, should not be on the same side of the bleeding point. That is the most important thing. So you are coming from here to here on one side, and coming from here to here on the other side. So that is the most important thing.
Sir, my question is, normally in a interruptive suture, you take one bite from one side and then take out the needle and then go to the other side. You have to go all through both sides, or you have to bring your needle.
Oh, yeah. I came through your question now. I got your question now. So you can come through the both edges at the same time. Doesn't matter.
But sir, okay, so there is no incision actually. But
yeah, there is.
They just got with the red dot.
Yeah, there is most of the time. For example, if you are opening the abdomen, if you're opening the abdomen, you have done the incision, and there is a bleeding point in the abdominal wall. For example, on the lateral abdominal wall and the abdominal wall, there is incision. So there is no 2 edges. There is only one bleeding point. You are seeing only one bleeding point. So you have to tie that bleeding point. So there is no, usually most of the time this is the situation, not this situation. So there is only one bleeding point. So you have to tie it from one side and then to the other side.
Needle should go through and through, one and other.
Yes, go through and through. Yep, 100% through and through.
All right. It's not like interruptive suture.
No, interruptive suture is different one.
I can understand, but it's not like taking the 2 edges is not like interruptive suture.
No.
There is going through and through.
Through and through.
Oh, sir. Thank you, sir, for your for understanding me.
No, no worries, no worries. Any other question, please? Okay, guys. Dr. Kamran, do you have question, or you're just amusing us with the...
I have a comment on the question that was just raised about making a figure of 8 stitch. I recently gave my exam, and I agree with the gentleman that just called in. And at the time of the exam, there is just a red dot on their model, the Rexine model, and there's no incision, no line.
So that is what I explained at the end, that when, for example, I said the same thing, that
yes, I agree. I agree with your comments about the opening the abdomen or whatever, but related to the exam, I think you, as you said, you have to make sure that you take 2 bites on each side of the dot, and when you make the figure of 8 and you tie it, naturally the dot will sink in, and I think that is what they want. And the other thing that I wanted to add was for the figure of 8 suture, the instruction said to use a monofilament non-absorbable suture. So they have 30 proline in the exam, and that's what the examiner asked me to use.
Yes. So related, the point related to the use of suture, you have to follow. They want to see that which suture you have the concept that which suture is which type. That is the thing. Second thing, you mentioned about this thing. So if they put this one, and if they have the line, that's fine. Otherwise, the main concept here is to go on the both sides of the dot.
Yes,
Both
exactly.
You have to take
And the other thing was, yes, and particularly to this station, if they ask you to make a suture, a figure of 8, they will ask you with 30 proline. They have 30 proline, and also they will like to you to count the number of knots that you make, and you should be making 6 knots because and then they'll ask you questions about why 6 knots, and then you have to tell them because proline has memory and can unravel and stuff like that.
Yes, 7 to 9. It is 7 to 9. So usually we put at least 7.
All right. I was under the impression it was at least 6.
It is 7 to 9.
All right. Exactly. Good.
Thank you, Dr. Kamran, for your input. Thank you.
Sir, last question.
Yes, please. Continue.
Sir, in single-handed reef node or double-handed reef node, like in absorbable polyfilament or braided suture, so we have to take again 4 or 5, 3 to 4 nodes, or just 1 or 2 nodes, and we have to show them that we can secure the node.
So it depends upon which suture you are using. If you're using, for example, this one, Vicryl, for example.
Yes.
Okay. If you're using a Vicryl, usually we use 3 to 5 knots. Okay. So at least 3 knots for the Vicryl.
So it's single-handed reef node.
Whatever it is. Okay. It has to be 3 to 5. Okay. So this is for the for the Vicryl. Okay. If it is, for example, Proline, then you have to do 7 and 9. So either it is single-handed, double-handed reef knot, instrument knot. This should be the number of knots are same.
All right, sir. Should we cut the needle first before tying single-handed, double-handed reef node or such a node?
I will never recommend that. I can. What is tomorrow? Tomorrow is Thursday. I'll go Friday. On Friday, I can record a small video. On Friday.
Right.
But I can, if someone remind me on the daytime. So I can record a small video how to secure it. This one, the needle, and do the other things. I have already recorded the single handed and double handed reef knots, but this one I can record that how to secure the needle. So you
No,
can.
sir, my question was before
You
tying single
cannot cut.
handed
You cannot cut before that.
and the tying at the depth like slip knot. Again, we have to keep the needle with the
Yes,
suture.
with the suture. Yes.
All right. All right, sir.
Yes, Dr. Shivani, you have the question. Okay, Dr. Nimra.
Sir, actually, I couldn't get the point when there is a single dot and there is no line or no cut. Then what we have to do, we have to take like 2 times needle on each side. I couldn't
Obviously,
get.
you cannot do figure of 8 without that. So here is, for example, this is the I again explain to you. No worries. But for example, this is the knot. This is the dot. This is the red dot bleeding. Okay, and you are asked to do the uh, figure of 8. What you will do, you will take your needle, come from here. This is your first point. This is your second point. This is your third point, and this is your fourth point. Okay, so you will come from here and exit here, and then you enter from here, exit here, and then you will do the knot. So this will be your figure of 8, and whatever the vessel will be, and the suture should be deep one, full thickness. Okay, so you will come from here to here, from here to here, and you will do the knot, and then after that you will the bleeding will be secured.
Okay, sir. Thank you so much.
Sir, I want to ask one thing.
Sure,
If
sure.
you allow. Sir, in the stations of when we are going to remove the sharps, is there a sharp bin labeled, or
Yes,
is
there
it the
is sharp.
color of yellow
Yes,
and red?
there is sharp bin, separate sharp bin. You have seen in your hospitals, small sharp bin. Sharp bin is there beside the table.
Okay, but what about the color? Is it colored
Yellow,
like
yellow,
yellow?
small yellow.
Yellow. Okay, okay, sir. Thank you. One more thing I need to ask about the excision of the navis. How would we calculate the length of the
In my video on, I have shared that one in the group as well 2 days before. I have recorded this video on my YouTube channel as well, so you can see that one. I
Okay,
have
sir.
explained
Okay. Okay.
in a very good way.
Okay, sir.
Okay.
Okay.
Thank you
Thank you, sir.
so much. Thank you so much, guys. Thank you so much.